Welcome to Inspiration Health Radio, sponsored by Millennium Physician Group. I'm Michelle McCormick. May is Skin Cancer and Melanoma Awareness Month, and with the summer sun starting to shine brighter and longer, it's more important than ever to take care of our largest organ, our skin. In this episode, we're going to hear from experts who know how to diagnose and treat our precious outer layer from all the harsh elements around us. But first, Millennium Physician Group is a leading comprehensive independent physician group in Florida with more than 700 healthcare providers at 150 locations in 19 Florida counties, serving nearly 500,000 patients. Millennium Physician Group, your connection to a healthier life. And you know what? Your Medicare matters here. Learn more at millenniumphysician.com. Connection, innovation, inspiration, health. Each week, we talk about the healthcare issues that are important to you by inviting providers and experts to inspire you to take control of your healthcare decisions. Join us right now for a healthcare journey as we work together to achieve the best health outcome for you. Well, according to skincancer.org, over 5 million cases of skin cancer are diagnosed in the United States each year, which makes it one of the most common. However, skin cancer is also preventable. Your first stop for skin care prevention and detection is always with your primary care provider. Our first guest today is Mark St. Lawrence. He's a Millennium Physician Assistant based out of our Bay Meadows Road East location, which is right near IKEA, near St. John's Town Center. Mark has been on the show before, giving us some great advice and wisdom. So, Mark, welcome back to the show.
Thank you very much, Michelle.
Well, skin cancer, big deal, big topic. We really need more than 1 month of educating people about the dangers of the sun. When a patient comes in to see you for maybe their annual wellness check or just their routine visits, how do you assess a possible skin ailment or cancer, if you will?
Very good question, Michelle. It's an ongoing talk, because the damage that we do and what we're seeing probably occurred in our early life, 10, 12 years old. It takes decades for a skin cancer to grow to something noticeable in most cases. So it is a long talk, from our first meeting, and it's something that we ask every patient, when you're in the mirror, when you're in the shower, if you see something that has changed rapidly, changed texture, changed size, changed color, those are the things that we need to be brought up in an office visit.
Yeah, so self-exams are very important in the case of your skin.
Absolutely. Because, you're in it all the time, and you are going to be the first one to notice that little patch of roughness, something that wasn't there a week ago, or something that has dramatically changed.
Right. So at what point do you, when you're seeing your patient, and this is a patient that you see maybe once or twice a year, at what point do you refer them to an actual dermatologist?
Well, there's a few steps. I'm very fortunate. I do a lot of procedures in our office. And if something has changed, if something fits into the criteria that we would use, we can do a skin biopsy, take a piece of it, send it off to the lab for pathology, and then, depending on the result, either go to the dermatology or, have them back in our office, and I would remove the remainder of that skin lesion.
Oh, well, that's fantastic. I love that you're able to do that at the primary care level. And what advice would you give your patients that don't quite have any skin abnormalities at this time, but maybe they're a little older? What advice do you give your patients?
It's all about protection. It's, those UV rays, are changing our cell structure a little at a time. And, that ounce of prevention is going to change dramatically, because I've seen, some of the worst case melanoma, as small as a head of a ink pen. It looked like a freckle, but it was black and glossy, and it had a little starry edge to it. And it was a melanoma, and that patient, had to have some deep resection of all that tissue. And then the ongoing care of, chest x-rays every year, because melanoma can move through the body once it's there.
Oh, so frightening. Well, Mark St. Lawrence, a Millennium Physician Assistant based out of our Bay Meadows Road East location near the St. John's Town Center. Thank you for joining us for the first part of our show on a very important topic, Skin Cancer Awareness Month. Coming up next, a Mohs surgeon who will join us to take a deeper look into skin cancer and all the treatments. Inspiration Health Radio is sponsored by Millennium Physician Group. We'll be right back. Welcome back to Inspiration Health Radio, sponsored by Millennium Physician Group. I'm Michelle McCormick. Each week, we talk about the healthcare issues that are important to you by inviting providers and experts to inspire you to take control of your healthcare decisions. Well, May is Skin Cancer and Melanoma Awareness Month, and with the summer sun starting to shine brighter and longer, it's more important than ever to take care of our largest organ, our skin. In this episode, we're going to hear from experts who know how to diagnose and treat our precious outer layer from the harsh elements around us. And according to skincancer.org, over 5 million cases of skin cancer are diagnosed in the United States each year. Makes it one of the most common. However, skin cancer is also preventable. Our guest today is Dr. Juan Carlos Martinez, a Mohs surgeon from Advanced Dermatology and Cosmetic Surgery. So, Dr. Martinez, thank you so much for joining us today. I'm so excited to have this conversation with you because we live in Florida. But let's first talk about yourself. Give us a little bit of background about you and what led you on this journey.
Sure. Well, first of all, thanks so much for having me. This is really fun. I love to do this kind of thing and to, spread the news and raise public awareness of skin cancer. I grew up in Tampa, so I grew up in the sun too, as all of us down here did, and probably got more sun than we needed to or than we should have. And so some of it is just kind of, paying the price of youthful indiscretions, as one of my professors used to say. But I grew up in Tampa, went to school up north in New Hampshire, and then kind of followed my education around the country. I went to med school at Mayo in Minnesota, and then I did my residency at Duke in North Carolina, and then I did my fellowship in Oregon, my surgical fellowship, before coming back down to Florida. And I was at Mayo here in Jacksonville for 13 years. And then just this past summer, decided it was kind of time for chapter 2 and have joined with Advanced Dermatology, and I'm just really enjoying the spirit there, the camaraderie and the way that it works. And so I've really had a good time, and it's fun. I love my job. I don't say to people that I've never worked a day in my life, but I love every day that I work. It's a really fulfilling specialty, and you get to take care of people and cure cancer and fix them, and it's just awesome.
I love that. I love that you went north to realize you needed to come back south.
Oh, yeah.
Those Minnesota winters, man.
It's not warm.
Well, we welcome you to the show, and of course to our area. We have a great relationship with Advanced Derm, and we're thrilled to have you today. So, is it important, and I think I know the answer to this, to have an entire month dedicated to skin cancer? I think it's something we really should discuss year round, especially living in Florida.
Well, for sure. I mean, the point of having the month is just to have something that we can at least focus on. If we screamed about it all, then people would probably start to ignore us. But it really is a real issue. We'll probably talk more about this later, but living in an era of an epidemic of skin cancer, in terms of how much skin cancer is being diagnosed, the tanning practices of the 80s and 90s are really catching up with us. The population of people that were tanning back then were, young teens and 20s. And then as that has kind of kicked into those people being in their 30s and 40s, that's typically the population that would be getting it anyway. So now you've got this acceleration of diagnosis of skin cancer. So there is a lot of skin cancer, and especially further south, as the latitude gets closer to the equator, there's just more skin cancer as you're dealing with people that have gotten more direct sunlight for a long time in their life. It is about cumulative exposure.
Right. And sunscreen, which we can definitely touch on a little bit later too, not something that is very popular back in the day. I went to college in Colorado, and it was super cold. But as soon as it turned 30 and the sun was out, we were out with our aluminum foil, trying to soak up the sun, because we had a really long winter of snow. So, and that was, I'm going to age myself here, but 30 plus years ago. So I kind of fall into that whole thing too, where we just were not paying attention growing up. You mentioned, all skin cancer, and, there's several types, but this is also Melanoma Awareness Month. So can you give a definition to melanoma and some of the other types of skin cancer?
Absolutely. So it's important to realize that cancers are named due to their cell of origin, or their organ of origin. So people talk about lung cancer. There's lots of different kinds of lung cancers. Same thing with skin cancer. You have different kinds of cells in your skin. You have the surface stuff. You've got sweat glands. You've got the follicles. And so all of those cells could theoretically go bad and become a cancer. So that's the big picture of skin cancers, includes all of those. But the three big ones that we talk about are basal cell carcinoma, squamous cell carcinoma, and melanoma. So I'll jump in on the melanoma because it is the awareness week. Melanoma are the pigment, melanocytes, are the pigment producing cells of the skin. And when those go bad, you have a melanoma. And they are something that can be early on in their life cycle metastatic. So they don't sit around. If they sit around your skin, nobody really cares. Or they can, but they don't spread and try to kill you if they're just sitting in the skin. But melanoma is one of the kinds of cancers that can start in the skin, and an innocent looking little speck that might be changing on you is actually also spreading through your body, and that's how it can really wreak havoc. So of the three common skin cancers, melanoma is the one that's most likely to be able to spread and do bad things like get into your other organs and even potentially cause death.
What little specks should we be concerned about, doctor? I mean, sometimes I have little red specks, or I have little white specks, or new specks. What specks should I be really starting to be worried about?
Well, I hesitate to do it over
the phone.
But no, really the main thing, and we might talk later about the ABCDEs, but something that's changing is the key. So not everything that's changing is a cancer, but if it's not changing at all, the likelihood that it's a cancer is pretty darn low. So cancers are going to try to change and grow and maybe start to bleed and things like that. So a pigmented spot that maybe is something that you've known you had on you forever and it hasn't changed, probably don't need to worry about it. If you're noticing a difference, particularly in a dark spot, those are the ones that you have to at least think about. If you've had a personal or family history of melanoma, those patients, that on top of a changing spot would really make you think. Any newer changing spot that's maybe starting to bleed that didn't used to bleed, that's something that we really want to take a look at. So the key to all of this is catching things early. And that's where a trained eye at a dermatologist's office is really what you need to get, so that if they need to biopsy it, they can, and if they don't, they can at least reassure that it's probably okay.
Yeah. So, speaking of moles and birthmarks and stuff, how do we know if those are something that are cancerous?
So moles are spots that are tumors to the extent that they are growths of those same population of cells. The melanocytes. So a growth of melanocytes is a tumor, but it is a benign tumor. So it is a non-cancerous growth. And those, almost everybody's got them. We tend to acquire them through our childhood and into our adolescence. So getting a new or changing spot, like if your kid is 14 and all of a sudden, hey, this mole is new, this is growing, that's when we get them. That's when they grow. So that's okay, typically. And when you get into your 20s, 30s, 40s, you kind of stop getting new ones, new actual nevi, which is what we call a mole in medical jargon. But a lot of them, believe it or not, start to go away. So if you see 90-year-olds, they don't have a lot of actual moles on them. They might have little dark spots, but not a lot of moles. So a lot of them go away. That's the kind of life cycle of them. But in terms of if you've got a lot of moles, the things that we typically look at as a clinician is the ABCDE. So that's going to be if something is asymmetrical. So typically they tend to be round or oval shaped. And symmetrical. If one half of it is clearly different than the other half, that's something that will kind of make us think. B is the border. So if it's got kind of a smooth, round, even edge, that's probably normal. But if it's kind of a scalloped edge and one of the edges looks like, like a landslide coming out of the side of it, that would be an irregular edge. That's something that you want to look at. Color is C. Most of them tend to be an even color. Sometimes there'll be some that are kind of speckled, but that can be okay. Typically, a person that has a lot of moles will actually have 3 or 4 different kinds of moles. So it's like if you have a bunch of little families on your body. And so you look at one and that looks like those 3 other ones that are on my right arm, or this one looks like the one that's on my leg. So you'll have a couple of different families. So they can be kind of speckled in color. Some are reddish brown, some are dark brown, some can be really black, but you've got a bunch of them. So as long as you have 1 or 2 even colors, but once you start having 2 or 3 colors or more colors starting into a kind of a gray look, that's when we start to wonder about it and think about doing a biopsy. D is for diameter. That's one that I don't personally use that much. We talk about 6 millimeters, which is basically the size of a red pencil eraser on the back of a classic pencil. So if something's bigger than that, but it's been bigger than that, it's okay. And if it's smaller than that, it can still be something that could be bad if it's new or changing. So I don't personally use the D all that much, but that's something that we sometimes talk about. Mm-hmm. And then I think the most important one is E, which is evolution or changing. That's the thing that you want to be, because you can have a brand new spot. And if you're 38 with a ton of sun and you have a brand new black spot and it's 2 millimeters tiny, I want to check it out. That's what, those are the ones that I want to look at. So evolution is the key one. And then a real quick one that we talk about too, sometimes we call it the ugly duckling sign. If you have one spot, even if it's with those other rules, but it just stands out from all the other ones, that's one that will often go for a biopsy.
Yeah. So A, B, C, D, E, and U for
U.
Yeah. And U. So I love that. I love that you guys have a way to really determine, and it helps patients to know that as well. My question, what about people who have maybe a lot of freckles and can't determine, is this a freckle or is this a mole or is this a new freckle as I age? It's a dark spot. How do you help your patients there?
So that's a great question. And the main thing, and not to make it sound like too much like a plug, but it's, get someone that knows what skin's supposed to look like. And especially if you establish a relationship with someone, they know what your skin looks like. And that is so important, that you're not seeing necessarily someone new every single time, because after someone's seen you, in continuity and maybe biopsy 2 or 3 things, they might start leaving alone the things that they were biopsying in the beginning, because that's just you and your skin. So, people that have a lot of freckles tend to be really fair people. Usually heavy freckling is a sign, at least, that you're getting a lot of sun, and that you're not maybe using as much sunscreen or covering up as much as you could, because freckles are basically just pigmentation in a splotchy pattern, and you tend to pigment up when in response to ultraviolet, damage. That is what it's doing. It's basically like, if you're at the baseball game and it starts raining, everybody puts up their umbrella. Well, the umbrella means it's raining. So when you're seeing everybody's tan skin or seeing everybody's freckles blowing up, it's because they're getting rained on with ultraviolet radiation.
All right. Well, we're going to take a quick break. Our conversation today with Dr. Juan Carlos Martinez, a Mohs surgeon from Advanced Dermatology and Cosmetic Surgery. We're going to come back and we're going to continue this conversation. We are going to do a deep dive into some sunscreen, and we're going to talk a little bit about Skin Cancer and Melanoma Awareness Month. So stick around. Inspiration Health Radio, sponsored by Millennium Physician Group. We'll be right back. Welcome back to Inspiration Health Radio, sponsored by Millennium Physician Group. I'm Michelle McCormick. Every week, we talk about the healthcare issues that are important to you by inviting providers and experts to inspire you to take control of your healthcare decisions. Well, May is Skin Cancer and Melanoma Awareness Month, and with the summer sun starting to shine brighter and longer, it's more important than ever to take care of our largest organ, the skin. In this episode, we are talking with experts who know how to diagnose and treat our precious outer layer from the harsh elements around us. And our guest today is board-certified dermatologist and fellowship-trained Mohs surgeon from Advanced Dermatology and Cosmetic Surgery, Dr. Juan Carlos Martinez. And thank you, sir, for joining us and taking time out of your busy May and talking about this really, really important thing that we don't need just a month to discuss. We live in Florida. The sun is ridiculously bright and hot, and our skin is very sensitive to that. But let's talk a little bit about the importance of having our body checked for these moles and freckles and spots that are, some people might think they're unseemly, but I think they're important to know what they are.
Yeah, we don't necessarily push for every single human being to have to get a skin check, but people, it's interesting. Usually I think by their time they're in their 20s or 30s, especially down here in Florida, they know when they've gotten a lot of sun, or they get a friend that gets something, or they have, as we talked about earlier, people that have a lot of moles and have had things taken off. They're aware of it. But the truth is that living in Florida is different than living in a lot of other places, not just because we're closer to the equator, but because we spend so much time outdoors too. You mentioned Colorado. People that live in higher altitudes can get a lot because the ultraviolet exposure is much stronger as you get higher up. But down here, we're just outside so much. I dress up my kids and we go out to the beach and we look like little beekeepers because I made a personal policy that even if I'm going for an hour, I'm going to do that trip hopefully like 10,000 times in my life. So The whole point is it's a cumulative exposure. We all get it. And there's places on our body that we can't see. And while it's true that the vast majority of skin cancers occur on the most sun-exposed areas, that's going to be the face, scalp, head, and neck, there are lots of skin cancers that occur on the arms, on the trunk, even in the genital regions, where you don't really think about that necessarily being a place that gets a lot of ultraviolet exposure, but especially melanomas can arise, they can be perianal, they can be vulvar melanomas. There are lots of places that you're not going to look. And so the importance of a full skin examination, at least, maybe the first time you go to a dermatologist, you might go in for just one spot that's concerning you, and you might get booked into a slot that's really just geared towards looking at one thing, but you should get a full skin examination at some point that is really, comprehensive, because again, there are places that you simply cannot see and that you need a trained eye to see to pick things up. Again, as I mentioned before, skin cancer really is all about catching it early. That is when you're going to have the highest success, both in terms of cure rates and in terms of it still being only in the skin. So an exam where someone's looking through your hair and moving your hair around and looking at your entire scalp. I do surgeries on scalp tumors, every single day. Those ones that are hard to find otherwise. A lot of patients fortunately have barbers that point out something to them, or dentists that notice something on their lips.
Yeah.
A lot of women who, the dermatologist may be the one that checks, because the gynecologist may say, oh, well, your dermatologist will check that, or vice versa. But the key is for the patient to recognize, hey, someone's got to look. Just make sure that someone looks, because there's some zones where some people are going to assume someone else has it, and it can get missed. So,
Dr. Martinez, is there a certain age that you should start something like this? I mean, I hate to say it, I have not had a full body scan, and it's something I absolutely need to get. I'm out in the sun. I try to wear a hat, but I miss some of my chin at times. My window's down in my car, so I know my arm's getting some sun while I'm driving around town. Is there, do you guys say at age X, Y, and Z, start this?
We don't really have an age, but real quickly, we can probably get you in, tomorrow or Wednesday if you want.
I'm going to call you when we're done.
We'll get a spot, but there's not a hard age for it, because it has to do with an individual's sun exposure history. So what I was trying to get at earlier, if you're a surfer and been surfing your whole life or playing tennis all your life, you probably want to get in your 30s at some point. In terms of the generic skin cancer check, anybody that's got a mole that's kind of concerning to them at any age, or a parent that's got a mole, 14-year-old or 17-year-old, that stuff is worth checking out no matter what. So let me back that up and say, when you're trying to rule out a melanoma, that could happen at any age, tends to happen older, but that's the stuff that's going to be like a changing mole. That any age, I would bring a patient in with that. But in terms of the generic, I don't know that anything's wrong, but I want someone to lay eyes on me, probably at some point in your 30s. Is someone living in Florida, maybe in your 30s, 35 or something like that. And if nothing else, you'll be able to get reassurance, and someone might be able to say, look, I don't feel like I need to see you every year, but we've established care. We've got you in the system. You know we're here. We know who you are. And if you need something, let us know. That always makes it a lot easier to get that patient back in. But if you've got someone that you want to see every 2 years at the beginning, but some of these patients now that they're 40s and 50s, I like to see once a year. If you've had a history of skin cancer, once a year, I think, is at the minimum. Some people that have had multiple skin cancers, we'll see them every 4 to 6 months, depending on the patient. Patients that have had melanomas, that's a different thing. There's actually kind of standardized guidelines for how often we like to see those patients. So those aren't really when, at a certain age they start, but once they've been diagnosed, you want to see them for a variety of reasons. Number one, a patient with a melanoma is more likely to develop a second melanoma. It's about an 8 or 9% lifetime chance of developing a second one. So you want to be able to catch anything new early. And then also, when that person has had surgical treatment for a melanoma, you want to make sure that it didn't come back, that it wasn't, missed somehow, and that it's coming back along the scar line. So that's called checking for evidence of recurrence. Or if it was a deeper melanoma that had a real chance of spreading, let's say, to the lymph nodes, your skincare provider will also do a really good palpation of the lymph nodes in that area, just to be sure. So those patients we like to see, depending on the thickness of the melanoma, every 3 or 4 months at the beginning for a year or two, and then we space it out to every 6 months or so for a year or two, and then you can space it out to back to once a year.
Yeah, I know my daughter, when she was a swimmer, swam outside in Florida during middle school and high school, had some, interesting moles, or if you will, on her back, and went to the dermatologist, and they removed them in office to have them checked. Can you talk a little bit about that process for those folks who do go in and something is detected?
Yes. So if the decision is made to biopsy something, there's really two different ways that can typically be done. We call them shave biopsies or punch biopsies. In both instances, the tissue is numbed, obviously, and then we're trying to get the lesion off. Now, for things that are suspected to be like a basal cell or a squamous cell, we're typically just trying to sample it. So we're getting a piece of it and actually leaving some of the tumor behind, so that if in the instance of Mohs surgery, for example, I can come in to do the Mohs surgery and really get right on the margin of the tumor because it's still there, even though a piece of it was sampled. It's like someone took a bite out of your birthday cake. In the instance of something that you were worried or suspicious might be a melanoma, the depth is absolutely the key factor for managing that patient. So the deeper a melanoma is, the more likely it is to do some of the bad things we talked about earlier, and therefore the surgical margins tend to be wider. If we get labs, or if we get scans or even biopsies of the lymph nodes, that will all be determined on the depth of that melanoma. So in that instance, you're not just trying to sample it, you're trying to get the whole thing off. And so that will typically be done either with something that's called like a saucerization, where you're doing like a shave biopsy, just kind of scooping it off with the razor blade. It might be a little bit of a bigger chunk, or you actually do what's called an excisional biopsy, where you actually cut it out in its entirety and actually stitch up behind it. And in that instance, if it turns out to be melanoma, you may have to come back to that site and cut out more.
Okay. Yeah. That's kind of sounds like what happened to her. So yeah. And I know when I was a teenager, I had one removed also, and it wasn't anything to be worried about, but it was something that they felt the need to remove in office. So in the next segment, we're going to talk a lot about Mohs and Mohs surgery, but let's touch real quick before we go to our next break about sunscreen, because this is a huge topic. You can get up to like 80, 100 SPF and UPF versus SPF. If you want to just kind of break that down for the listeners, that would be amazing, because it's very important.
Yes, it's totally very important. I will do my very best. So the big picture is you are trying to apply something on your skin that is blocking the ultraviolet radiation from doing the damage that it does to DNA. Okay. And there are different ways that you can do that. You can put on a substance like the titanium or zinc that is literally a micro thin sheet of metal, right? That's what titanium and zinc are, and is working as what we call a physical blocker. It is literally like if you had tinfoil on your skin, the UV doesn't go through it. It's that premise. The other ones that are with the avobenzone and the oxybenzone and some of those other chemicals that can sometimes get a bad rap for what they're doing to coral and things like that. I won't go too far into that, but suffice it to say that they are safe for use in humans. We would not use them and put them in sunscreens if they weren't. But those work, interestingly, by absorbing certain wavelengths. And in those, it's really important to make sure that the label says that it's a wide protection or broad spectrum protection. So you're covering both UVA and UVB radiation. And that's basically done with a mixture of chemicals that's going to absorb across a broad spectrum of the electromagnetic radiation that we're trying to keep from getting down to the skin. Some other things that are neat that are basically free radical absorbers. So the way that the ultraviolet radiation does damage is by getting into your skin and causing free radicals, which then cause damage to the DNA. You can actually put things that are absorbed into the skin and then are basically absorbing the free radicals like little sponges, and they're not letting, the ultraviolet radiation comes in, but then the damage can't get caused because it gets soaked up by something else. Those are the least common ones. So the two main ones are going to be the UVA, UVB protection that is coming from the avobenzone and oxybenzone and some of those other chemicals, and then the physical blockers. That's the way that you can protect it. Now, the way that we measure how protected you are, that's what SPF is and UPF is. And that has a lot of kind of mystery that is not that mysterious to it. But the big picture is the more you protect, the more you're going to save your skin. Okay. So, and the other truth is that the way that those numbers are measured is in a laboratory and is frankly on a little poor little pink pig that they, put the stuff on, they hit them with ultraviolet, and that's how, it's a certain amount that gets put on there. And nobody, except sometimes my dad, puts on the sunscreen as thick as it's supposed to be. So when you make fun of your friend because their cheeks are white, that is actually right, okay? That is how much is supposed to be on you to get the number that's on the jar. So by the time everybody has kind of put it in there and rubbed it, it's just really dilute. So it's kind of like if you made the Kool-Aid and put way too much water in there, then it's not really the strength that you have on the jar. So when people say, oh, well, I heard somewhere that the 100 is all just, the company's trying to make a buck because it doesn't really matter. It does matter because you want the higher one because everybody's going to dilute it anyway. So you want to have a higher number on there, especially if you're doing something like golf or tennis or beach or something like that. If you're just using the daily cover, the daily moisturizer that has some SPF, sure, those are 15s and 30s, and those are great to use on a daily basis. Find the one that you like that doesn't make you break out, that works for you, and just use it every day. Those are really, really functional and really good. If you're going to the beach, you got to use the bigger numbers. You got to use your 55s, your 75s, your 100s, because you're not going to put it on that thick, and you're going to sweat it off. That's the other reality.
Right.
They're not allowed to say that they're waterproof anymore, which is great because nothing's waterproof. So you got to put it on there. It's going to come off with sweat. It's going to come off in the water. It's going to come off when you towel dry. So the key really is to reapply when you're going out to the beach. And then you were talking about the UPF, the fabrics. Like I mentioned, the reality is that although those can be really effective, the sunscreens, it's a pain sometimes to put on that stuff all over, and it's messy. And so I personally find that a big hat and the little beekeeper look with the shirts are really comfortable, and especially in Florida, it feels good because you get it wet and then it's kind of cool all day while you're wearing it at the beach. So I really like the fabric and the clothing, and they do a great job of protecting. They do have to be rated because it has to do with how tightly woven that fabric is to block it out. If you're just wearing, one of those cool little, Panama Jack hats that like leaves you can see all the sun coming through it, it's not helping you that much. Or like some loose t-shirt that you can get a burn through that stuff. So you have to wear the right clothing, and it should be rated, but those can be really, really effective.
Yeah, and they've come a long way. The shirts have come a long way. They're very stylish now. Yes, so just saying, wear one.
The last thing I was going to say is the sprays that have become more popular in the last 5 years or so. Everybody's watched like the mom, from 100 yards away spraying the little kid, and it's just like a cloud that's going down the beach, and like it's like a tenth of it is on the kid, right? So I personally like to spray that in my hand and then wipe it on the kid. That's just a personal tip. I don't know if there's any science behind that.
Right.
If you want to get it on the kid, you got to get it on the kid. So you want to be careful with that.
Well, I love, one of my most favorite things to do on the weekend is put on my floppy hat, like you said, because we got to cover it all. But I spray on my way out. So I take the spray and I rub it in really good, and then I go sit out by the pool. But I should be putting on my sun shirt because, it's nice looking too. So, all right. Well, we're going to take a quick break. Thank you for that. Dr. Juan Carlos Martinez, a board-certified dermatologist and fellowship-trained Mohs surgeon from Advanced Dermatology and Cosmetic Surgery. We're going to come back and learn about Mohs surgery and hear kind of what his specialty is all about. So stick around. Inspiration Health Radio, sponsored by Millennium Physician Group. We'll be right back. Welcome back to Inspiration Health Radio, sponsored by Millennium Physician Group. I'm Michelle McCormick. Each week, we talk about the healthcare issues that are important to you by inviting providers and experts to inspire you to take control of your healthcare decisions. Well, May is Skin Cancer and Melanoma Awareness Month, and with the summer sun starting to shine brighter and longer, it's more important than ever to take care of our largest organ, and that's our skin. In this episode, we are hearing from experts who know how to diagnose and treat our precious outer layer from the harsh elements around us. And joining us is board-certified dermatologist and fellowship-trained Mohs surgeon, Dr. Juan Carlos Martinez from Advanced Dermatology and Cosmetic Surgery. And Dr. Martinez, we have really covered a lot, it's been so amazing. One thing that I did, 1 in 5 people apparently will have some form of skin cancer in their lifetime. Is that right?
It's incredibly common. Yeah. Basal cell carcinoma is the single most common cancer in all mankind. And that's the most common one. And squamous cell carcinoma is not that far behind it. It's about 1/3 of the number of cases as basal cell. And then of the of the common skin cancers, melanoma is the 3rd most common. But that's the one that we talk about more because that's the one that more likely to do things like metastasize and cause death. But it's important to recognize that squamous cell carcinoma absolutely can do that too. And while basal cell carcinoma, which again is the one that's the most common, is very unlikely, essentially never metastasizes, they can, because they're slow growing and because they're not spreading and killing people and because they don't hurt, just continue to sit and grow and be destructive wherever it is that they are, be it your lip, your nose, your back, your cheek, your forehead, wherever. The best analogy that I've been able to come up with for basal cell carcinomas is like a spot of rust. It's there. It's not doing anything egregious, not doing anything catastrophic, but if you don't deal with it, it is going to make a mess. And that is exactly how those can work.
Well, let's talk a little bit about your fellowship trained Mohs surgeon title that goes along with what you do at Advanced Dermatology. What is Mohs? What is a Mohs surgery, Mohs surgeon? I tried to do some looking up on it, and I was like, people talk about this all the time, but I'm not quite sure what it is.
Yeah. It's a great question, and a lot of people always wonder what Mohs stands for. It sometimes gets capitalized and apostrophes in weird places. But the long and short of it is it's a technique of examining tissue, okay? And it was named after a great doctor named Frederick Mohs from Wisconsin. He came up with it when he was a medical student at the University of Wisconsin in Madison. In the 30s, he kind of pioneered the concept of basically fixing the tissue on the patient, cutting it off while it was on the patient, and then making slides to evaluate the entire border of what had been cut off. And essentially, in the 70s and to what we do now, we use what's called the frozen tissue technique, where we cut the tissue off of the patient. We immediately stop bleeding and put a bandage on the patient, and then we go and concentrate on the tissue itself. And what the method is essentially you take as narrow as possible a margin. So if I see a patient that's got a pink little spot, I'm going to draw on the edge of what I see, and then the width of my little ink pen line, about 1 to 2 millimeters, that's going to be what my margin is. That's how far outside what I can see with my naked eye I'm taking. But then the beauty is that the technique, and this is easier to show, I don't know how to explain it as well over radio, but you're basically taking something that's like a bowl, so maybe think of a pie tin, and then you flatten it down. So like get an elephant to step on your pie tin, okay? So now the entire periphery walls of the pie tin are sitting flat on the floor, and they're on the same plane that the bottom of the pie tin was on. But what you're looking at used to be the kind of side wall of that little specimen as well as the base. And so if you can get that pie tin and look at it from the underside, from the street side, that's what our techs do and make microscope slides out of it. And then I and a Mohs surgeon will look at the tissue under the microscope. And what you're looking at is every place essentially that the blade separated that tissue from your body, okay? So if I see normal everywhere around and underneath, now I know that the tumor that you had that was proven by a biopsy was inside of that little thing that came off of you. And that means you're cured. You don't have cancer anymore. And I looked at 100% of the margin. But if I see tumor somewhere, the beauty of the technique is I make a nick in the tissue and we ink it, and I know exactly what's up and down under the microscope slide as compared to on the patient. And if I see a little blip of tumor on that microscope slide, I know A, that there's more on the patient because otherwise it wouldn't be on my slide. And B, I know exactly where it is on the patient. So now I'm going to come back to the patient. I'm going to make sure they're still numb. And that process has taken anywhere from 30 to 45 to 60 minutes, sometimes 90 minutes if the lab is really busy or if the tissue is really big. And I'm going to go back to the patient, make sure they're still numb. And now I'm going to cut a little bit more. But the beauty is I only have to cut from where I know there's still tumor. The corollary to that is I'm leaving alone everything that I already proved is cured because I don't need to take any more if I don't need to. So now we take a little bit more, do the same check on it. And if it's positive, take a little bit more. If it's clear, now you're clear. So the downside, if you will, because everything in life has downside, the downside of Mohs surgery is that it is a time-consuming process, and there's no way around that reality. The upside is that you're evaluating 100% of the marginal tissue. You're able to provide cure rates that are 98 to 99%, which is as high as it gets in the cancer world.
Right.
And you're able to, most importantly, perhaps, you're able to leave as much of the tissue on the patient as you possibly can that you needed, right? So because that's the case, it is something that is used predominantly in areas where you're basically dealing with, high value real estate, eyelids, lips, nose, anything on the scalp, face, neck, anything on the genitals, anything on the hands or feet. In areas that are less important, let's say it's on your, on your backside, on your elbow, something like that, you may not need Mohs surgery, because taking a couple extra millimeters or even a centimeter more, it's not the end of the world. And so we don't necessarily have to use Mohs in those instances. Now, you don't ever have to use Mohs, something that I used to always tell my residents when I was working at Mayo, and everything would have a higher cure rate if you did. But that's like saying, yeah, it'd be awesome if I took my kids to the bus stop in a Rolls Royce every day. I'm sure they would like it, but you don't need to do that. And so, or at least I don't feel like you need to do that. So what you're wanting to do is use something judiciously, but use it where it can really shine. And that is, again, going to be locations on the body where you really want to preserve every last millimeter of the patient's tissue, or when you really, really need to make sure that you got the tumor out. And that's going to be certain kinds of tumors. Certain subtypes of basal cells or squamous cells can be more aggressive or can be sneakier. They can be harder to detect with other methods of excision, or other methods of treatment will have lower cure rates. So that's where the Mohs technique will shine and let you provide that highest cure rate with the most amount of tissue sparing. So that's what the Mohs technique is. Now, who does Mohs? Typically, it tends to be people that did a dermatology residency first. Interestingly, Fred Mohs was a general surgeon, but his lab space was in the Department of Dermatology at University of Wisconsin, and that's how it fell into the world of dermatology. And so it is typically people that have done a dermatology residency. And then there is, you can't forbid people from doing certain procedures. So not everybody has done a fellowship, but does exist a fellowship training pathway. And people that wanted to get the best possible training, so after they got exposure during their dermatology residency in skin and in skin cancer and in dermatopathology, then you can do a formal training, which is 1 to 2 years of exclusively doing Mohs surgery, cutting out skin cancers, learning about skin cancer, and learning how to read it under a microscope. And beautifully, also the reconstruction, fixing the holes that we make. That's something that is really one of the beauties of the specialty as well. So we do cutting out, we do the checking, and we do the fixing. And that is something that is really part of the cutaneous oncology and Mohs micrographic surgery fellowship, which is an extra added layer of training after dermatology residency.
Yeah, I was going to ask about the after the incision. How do you fix, especially if it's in those very high real estate areas you were talking about? If it's on my nose or my forehead, how do you make it look not so cutthroat, if you will, not so cut up?
Yeah, absolutely, and that's, to be perfectly honest, that's people's main question, often more so than the deadliness or the potential threat of the cancer. They don't want to look bad. You don't want to be disfigured. You want to be made whole again. And so that is one of the beauties, again, of the fellowship training, and also one of the beauties of what we have going with advanced dermatology is that we have a team approach in which the Mohs surgeon in North Florida, I'm doing the Mohs surgery, and I've got a fantastic partner who is a board certified plastic surgeon, Amy Brewster, and we're a team. And so I'm doing the Mohs surgery, and she's doing the vast majority of the reconstructions. And I'll jump in and do a couple of closures during the day as well, but she's doing the bulk of the complex and complicated reconstructions because that's what she does too. And so it's really a team approach that lets us shine, really does.
That's awesome. Are you removing the skin with a laser or with like a scalpel?
It's a scalpel. No, and there's no laser involved at all. Yeah, and so that's to your point. Some people think that Mohs is magic or something. No, it's just I'm cutting a circle or I'm cutting an oval, and really the method of the margin examination, that check under a microscope of every single marginal millimeter that's what makes Mohs special, and that's. Otherwise, we're just cutting a little circle and checking it really carefully.
Well, congrats on your fellowship training, Dr. Martinez. Now, tell us, as we close the show, give us a few pieces of advice that you can leave with our listeners today about Skin Cancer and Melanoma Awareness Month.
Well, the main thing I would tell you is if you've got something that you're worried about, get it checked out. If you've got something that you're not worried about, but all of your friends are worried about, get that one checked out. Or if you've got, a friend or family member that's telling you about something that's changing. If you've got a strong personal family history, but don't really have anything that you're worried about, but you've got a lot of sun, those are just get in and get seen and establish care somewhere. The main thing living in Florida is just be smart. We know better now. It's a lot of patients are talking about, we used to use baby oil and iodine and all that stuff, but we didn't know better. We know better now. I go out there and people are still cooking. So don't cook if you can help it out there in the sun. And if you do, that's okay. Be out there. You don't have to be a hermit, but be smart. Wear enough sunscreen, reapply, or look into the big floppy hats and the sunglasses and the long sleeve shirts with the good UPF protection. It's really comfortable, and you can pay the price. I can't tell you how many of the 70 and 80-year-old patients that we see way too often, right? We're seeing them every month, some of them, or every 2 months. We'll just say, God, I wish I knew, or I'm going to go show my grandkids this hole that you made in my nose. And, it really is, it's kind of like cigarette smoking, right? It doesn't hurt right now, but it's bad for you in the long run. So you really got to be smart. We are in an area where high sun damage is endemic. Even walking, in and out of the parking lots doing errands is significant sun exposure, more than a lot of people up north.
And it doesn't take very long.
No, it doesn't. It doesn't. So just be smart. Cover yourself up either with clothing or with some good sunscreens and reapply, and just get something checked out if you're worried about it at all.
Well, before we say goodbye to you, we're going to welcome Shane Reinhart, who is going to give us all the contact information about advanced dermatology and cosmetic surgery. So Shane, how can we find you and Dr. Martinez in your locations across the area?
Yes, thanks again, Michelle, for having us. Here's the reminder for our listeners, advanced dermatology and cosmetic surgery. We do have 7 locations and 16 providers, including Dr. Martinez and Dr. Brewster, who you mentioned earlier, throughout the Northeast Florida region. You can either find us on our website at www.advancedderm.com. And whether you're along the coast or in central Jacksonville, we have the dermatologist that will see you now.
All right. Well, I need to give you guys a call. So Dr. Juan Carlos Martinez, board-certified dermatologist and fellowship-trained Mohs surgeon from Advanced Dermatology and Cosmetic Surgery. Sir, thank you today for joining us, and I really appreciate all your insight and advice during this Skin Cancer and Melanoma Awareness Month.
Yes, thank you so much for having me. It was my pleasure.
Well, thank you. The conversation will continue next time on Inspiration Health Radio. Your skincare too, journey is important to us, and our goal at Millennium Physician Group is to work together to achieve the best health outcome for you. Always starts with seeing your primary care provider. See our website for a full list of offices and providers at millenniumphysician.com. In good health, I'm Michelle McCormick. Have a great day.